Welcome everyone to this lecture on COVID vaccines, the safety and risk factors and the practical aspects of the COVID vaccination. What are the things that one has to really watch for? What are the precautions one has to take? And also a little bit on the cases that have been seen during his own personal experience. We have with us a very well known allergist, Professor Stanley Fineman. Professor Fineman is a dear friend, but most importantly, he is the professor, the Department of Pediatrics at the Emory University School of Medicine in Atlanta, Georgia. He's the past president of the American College of Allergy, Asthma, and Immunology. And he was also the board member of the World Allergy Organization for several years, including during my presidency, and has been very active in the field of anaphylaxis, food allergies, and asthma. He's currently also the international advisor to Apache's Committee on Food Allergy and Anaphylaxis. So welcome, Professor Fineman. We look forward to your excellent lecture, your case presentations, and to the discussion that follows.
Hello, everybody. This is Dr. Fineman. I'm an allergist in Atlanta, adjunct professor of Emory at Emory University School of Medicine, and I wanted to thank Apache for inviting me to present this program on adverse reactions to COVID vaccines. And I'd like to make it interactive, and we'll have a good question and answer session afterwards. The reason we wanted to bring this up is because since we've started doing the COVID vaccinations here in the United States, we've seen a number of reactions which have been very disturbing. This was a report from the Journal of the AMA that was just published last week, in fact, that summarizes some of the reactions that they've had with the COVID vaccines between December and January. And the two that we have available now in the U.S. are the Pfizer BioNTech and also the Moderna vaccine. And what they've found is that the rate of reactions you can see here. Initially, they thought it was very high, much higher than we would have liked, like 11 per million in the Pfizer and 2.5 per million in the Moderna, but it looks like they're closer to 4.7 cases per million in the Pfizer and 2.5 cases per million in the Moderna, which is still very disturbing. But if you look at the breakdown of the symptom onset, most of them are having their symptoms within 30 minutes of receiving the vaccine. Most of them are having the reactions when they receive the first dosage of the vaccine. And this is the Brighton collaboration definition level, which is basically an assessment of whether or not it's true anaphylaxis or not. And between half and really most of the cases pretty much are suspect for having true anaphylaxis. And, because of these problems with the anaphylaxis to the vaccines, a group in the U.S. has put together recommendations that were published. In fact, they're in press right now in the Journal of Clinical Immunology and Practice. And you can see that they basically broken down some of the ingredients, the incipients of the vaccines, the Pfizer and the Moderna, and they found that the common ingredient here is the PEG, the polyethylene glycol, in both the Moderna and the Pfizer, and they feel that that is probably the most allergenic product that may be producing these reactions. This is a chemical structure of the polyethylene glycols, and you can see this is polyethylene glycol here, and you can see in the polysorbates, it's in these, it's many times in the molecules. But the bottom line is they decided to come up with a questionnaire that you can ask patients, and we started doing that the minute they came out with it. So basically the 4 questions are: do you have a history of a severe allergic reaction to an injectable medication, either intravenous, IV, IM, or sub-Q? We're going to talk about that because, in fact, most of the patients who've had reactions have had some kind of a prior allergic reaction. Number 2, have you had a history of a severe allergic reaction to a prior vaccine? Number 3, have you had a history of a severe allergic reaction to another allergen, like a food allergy or a venom, or maybe even latex? So those are the top 3 questions. And then the last question is, have you had a history of an immediate severe allergic reaction or a severe allergic reaction to polyethylene glycol, PEG, or polysorbate, either containing injectable or a vaccine? So, and basically they have a little algorithm here. So if you answer no to all the 4 questions, then you're considered to be at low risk for having a reaction to the vaccine. In other words, you don't have a history of prior anaphylaxis. You don't have uh, mastocytosis or mast cell activation. Maybe you'll have allergic rhinitis or asthma, but that doesn't really make you a higher risk for a reaction to vaccine. And so the recommendation is to wait 15 minutes after you receive the vaccine. If you answer yes to the first 3 questions, the ones about severe allergic reactions to prior vaccines or medications, then you should wait 30 minutes of observation, okay? So this is a potential history of potential anaphylaxis to a vaccine or injectable without PEG. Then you should wait your 30 minutes. Or if you have a history of, let's say, a drug allergy, a food allergy, something like that. And then the ones that are higher risk are the ones who have answered yes to number 4, the question about PEG. So those are the patients who have a history of having a reaction to an injectable with PEG and are at risk for anaphylaxis. Okay, those they recommend further evaluation and expanded skin testing. And we're going to talk about that in just a minute because I'm going to give you some experience that we've had in our clinic. So the expanded skin testing procedure is listed here. What they recommend is they basically you do a skin test with PEG, and it's commonly in Miralax. I'm going to show you this in just a minute. There's other medication that the PEG is in, like the methylprednisolone or Medrol. It's in the triamcinolone, Refresh eye drops. That contains polysorbate. That doesn't contain PEG, but they recommend testing for that too. And if you want to go further, you can go to the polysorbate that's in the hepatitis and also the or the Twinix vaccines here. If the skin test is negative, then they recommend going to intradermal. These are the puncture tests. They recommend going to intradermal, which is a little higher dose of the PEG or maybe the polysorbate. And then if the skin test is negative, then with informed consent, they recommend giving the vaccine under observation and waiting 30 minutes. In other words, giving it under the allergist supervision. And we should talk about this too, because not at my clinic, but another clinic at Emory last week, they did this protocol, and they had patients after they had the negative intradermal skin tests. They did test dosing. In other words, a graded dosing. They gave a small dose and then the full dose, and that may be a better way of doing it than just giving the whole dose at once. But right now we're not able to do that because we don't have the vaccine in our clinic. So this is the risk stratification again. If you've had the reaction to the first dose, then you need to have a full evaluation. You're considered at high risk and maybe even ineligible for the dose in some of these patients, especially if you have positive skin tests. But you may have to have what we call shared decision making for the second dose. And some patients maybe not wanting to do it. The low risk, of course, are the ones who just had local reactions, and those you can either do a 15 or 30-minute observation. And then the medium risk, you can see here, again, you should have the skin testing, and as long as the skin testing is negative, then consider the 30-minute dosing. One of the things that they do point out in the article, which I think is helpful, is the difference between a true anaphylaxis and a vasovagal, because as you all know, it's not easy to differentiate between vasovagal reactions and anaphylaxis when you present with these types of reactions. The biggest thing I think is the difference with the level of consciousness here. Frequently with the vasovagal, you get the fainting sensation, sometimes dizziness or loss of consciousness. You get relatively slower breathing, little slower pulse, and you get diaphoresis. Whereas with anaphylaxis, it's more, you get more anxiety basically, you get respiratory problems, your pulse is more weak, and generally you get hives or you get pruritus. And in 90% of the cases, I think you're going to see a rash if it's true anaphylaxis. The other point is hypotension. Usually, hypotension is more sustained with true anaphylaxis. It's maybe transient in vasovagal where the patient may faint. But some of the other symptoms may be the same, such as the GI, the nausea, vomiting, things like that. So it's not an easy thing to differentiate. What we did in our clinic is adapt the recommendations for skin testing that were in the Menagerie article that I just showed you. And so we're basically testing for PEG and for polysorbate, and then we have the control here. And this is what we've set up: is we have the Miralax, we have the depomedrol, we have solumedrol because that's a control, and then we have the refresh eye drops, and we just do that, with these dilutions here. And this is the way we've mixed up the Miralax in the different concentrations. This is the way we've set up the different intradermals as well with the solumedrols, and then of course the refresh uh, uh, product as well. So let me go through some of the patients we've done thus far. So these are the patients, and the first patient here is a patient who is 74, and they had a rash, and I just want to pull up some notes here while I'm talking. They had a rash with erythema at the injection site. It occurred 6 days after the first dose. So that's a little bit strange. And in other words, I really, I'm a little concerned about that being related to IgE. But be that as it may, we went ahead and tested her, and she was negative, but she's adamant and she doesn't want to get the second dose. So this is that patient. Now, one of the things I didn't say is that when they looked at the immune response after giving a PEG type therapeutic, what they found was, and this is recorded in that Menagerie article, was that 70% of the patients had an IgG response, and only 0.1% had an IgE response to products that contain the PEG. So it definitely can produce an immune response, and maybe that delayed reaction was more of an IgG response. There's no way to know that really. So this next one is a male, a 49-year-old male, who was a physician, and he had a history of a prior systemic reaction to an injectable penicillin. And he had this aura, he called it, within minutes. And then he had, this is the first Moderna vaccine, he had tingling of his lips. He didn't have any rash, he didn't have any dizziness, and he went ahead and worked the whole day. But he said the lip tingling lingered a little while. And when we did his test, they were negative. He's looking to get a graded dose of the second dose of Moderna. So we'll probably do that once we get that in. The next patient is a 77-year-old who, after the first Pfizer vaccine, had flush-faced, no rash, but she had a history of rosacea. So, sometimes you wonder, well, maybe the flushing has to do with the rosacea. It was just hard to say. She didn't have any photos. Her skin tests were negative, and my understanding is she's planning to get the second dose, but hasn't gotten it yet. The next is a younger patient, a 27-year-old. She has a history. I forgot to say, the 77-year-old did have a history of food allergy and insect allergy. So she was like really, concerned about having another allergy. The 27-year-old was a nursing student. She had a rash on her legs after the first vaccine. She got a little short of breath, but then she got some more hives. She'd only had a history of some allergic rhinitis, and we tested her, and I think she's also going to get a graded dose for her second. The next was a interesting patient, with 52-year-old, who did have some reaction about 3 weeks after the first Pfizer vaccine, and this progressed over the next 2 hours, became generalized. And even though her skin tests were were negative, she was adamant that she's not getting the next dose. She refused to do that. The next one is a 53-year-old female, and she has a history of toothpaste sensitivity, which does contain PEG. And she's concerned about a PEG sensitivity because she said, well, I don't want to get any vaccine unless, because if I get trouble with toothpaste that have PEG, then maybe I'll have trouble with the vaccine. So we tested her. She was negative, and we haven't heard whether she's gotten her vaccine yet or not, but we recommended a 30-minute wait for her. The last patient we've done so far is this 54-year-old female who, within 3 minutes after receiving the first Pfizer vaccine, had pins and needles on her upper body. She had a little elevation of blood pressure. A little elevation of heart rate, her blood pressure, and she felt lightheaded. So, that's a little hard to say if it's true anaphylaxis or not. She had a history of a drug allergy to sulfa, but that was really all she had a history of. So one of the things that I think is interesting that we've been looking at is the fact that other patients have reported, or other people have reported, untoward reactions to the polyethylene glycols and polysorbates. And this is an interesting report from a few years ago in the Journal of Allergy, Clinical Immunology and Practice from the folks in Tennessee, where they had 2 patients. And the interesting thing about these 2 patients is I'm trying to find my notes here, but the bottom line is that they were both mechanics. These were both males. They were both mechanics, and they both developed significant immediate reactions to PEG that was in bowel prep and products such as Miralax. And when they did testing on them, interestingly, you could see they had positive reactions, even on the prick tests to the PEG. At least this one did. This one had, and one of them had a systemic reaction after an intramuscular, after an intradermal injection of the PEG as well. So it doesn't really show here, but they basically had a severe reaction to the PEG when it was done on an intradermal way here. But you can see the big reactions that they had. There's even a picture of them here of the big, large reactions on the skin tests. And what was concluded in this article was that the higher the molecular weight of the PEG, the greater the odds ratio of the patient having a reaction. So they were more likely to have a severe reaction at the higher molecular weight PEG than the lower molecular weight. And this is just the case reporting of the history of allergic reactions or anaphylaxis to PEG that has been reported to the FDA from 2005 to 2017. And it's pretty small. It's only about 4 cases, which is really not very many. But if the patient has the problem, then it's significant and probably not that easy to diagnose. Here's another report. This is from the UK that was published this year in the Journal of Clinical Immunology and Practice. And this is a 5-case report, 5 patients who had a history of severe reactions or anaphylaxis after products with PEG. And they had skin testing, again, who had positive reactions to the skin tests. This one also had a anaphylaxis to an intradermal, and this one had anaphylaxis to an intradermal test with the PEG. So again, these are cases who have untoward reaction to PEG. These are even before they had the COVID vaccine or anything like that. Interestingly, the World Allergy Organization and it came up with a recommendations in the anaphylaxis committee. I'm on that committee, and also Dr. Thong is on that committee. Unfortunately, he's here today, so he can comment as well at the end of my didactic presentation. But they came up with some recommendations that are listed here. This was just published last week, where you can proceed with the vaccination in certain situations, such as the patient may have had a history of a food allergy or other history of allergies, things like that. But special precautions would include things like if you've had allergic reactions to multiple different drugs, maybe, or if you've had anaphylaxis to a parenteral antibody preparation, or maybe idiopathic anaphylaxis or mastocytosis. And the action would be assess the risk of a PEG, consider an allergist. Here's where you might consider allergy testing, and I think we should talk about that. That's not specifically spelled out in this article, as it was in the US article. And of course, they recommend no vaccination at all when the patients have had severe reactions to vaccinations, especially reactions to PEG. And they said don't vaccinate and refer to an allergist. Again, I do want to cite the fact that Apache has a phenomenal paper with recommendations for adverse reactions. I have it cited here, and I think that Professor Pawankar is going to send that out to everybody here. I think one of the things that's very good about this review is not just the fact that it has so many references that are very current and up to date, but it does have specific recommendations, such as number 14, when it talks about erythema multiforme, Stevens-Johnson's. You should take precaution there. Also, healthcare providers vaccinating against COVID. They need to be able to treat anaphylaxis properly. So, in other words, when you're giving the vaccine, you want to be in a situation where you can treat it properly and promptly, and make sure that you can handle the patient if they do have an anaphylactic reaction. And so that's the end of my slides, so we can start our discussion. So I hear you, Bernard.
Thank you very much, Professor Fineman. That was an excellent talk. And I think it's very, very useful to our membership and our community here in the Asia Pacific, because in the Asia Pacific is just rolling out the vaccines, with Singapore and India being the two countries that have actually rolled it out even faster than others. Japan has just started rolling it out to the healthcare professionals, healthcare workers last week. So it's a very timely talk, and thank you very much for even giving us examples of cases that you have personally seen, and the manifestations and how they were managed. So in doing so, I'd like to now also invite Professor Thong. Professor Thong is our board member and a co-chair with me for this task force, has been intricately involved not only in developing these recommendations, but also actively involved in Singapore with the Singapore government in this project of vaccinations. So I'll ask him to initiate all the questions first, and then I'll follow up after that. So Bernard, please.
Thank you very much, Ruby. I think that was an excellent coverage of what's the situation in the US. I think in Singapore, things are a little bit different. So even though in Singapore and India have rolled out the COVID-19 vaccinations in both the countries, but I must say that in Singapore, the approach is a little bit different. It's not as fast as is the case as to how it's being rolled out in the rest of the world, and partly because the community prevalence for COVID-19 infections is rather low. So we still do get quite a number of cases on a daily basis, up to about 15 or 20, and these are largely imported cases, partly because we have opened our airspace to limited travel. In particular, for example, people who are working in Singapore who need to come in here. some of our overseas labor force as well. So our speed of vaccination, you could say, is not as quick as we would like it to be. And one of the reasons why that is also so is partly because since we started out rolling out the Pfizer vaccine on the 8th of January, we have also received our first consignment of the Moderna vaccine, and this was approved in Singapore on the 3rd of February, and it has come in on the 18th of February. But in our experience, when we first started vaccinating about a month ago, we've seen quite a number of fairly interesting reactions. And in fact, we do seem to see quite a number of delayed reactions. So I'm not sure what Professor Steinman thinks about it. I saw your examples just now. It was quite interesting. The patterns that you see are fairly similar to some of the patterns that we saw in our staff, the healthcare workers who were vaccinated during the initial 3 weeks and 4 weeks. We do see quite a number of delayed reactions, and we have individuals developing urticaria, angioedema, even as delayed as 2 days, and sometimes up to about 7 to 8 days after the vaccinations. And these are individuals who have never had recurrent episodes of urticaria, angioedema before. So I'm just thinking, what do you think are the mechanisms underlying this? It doesn't seem very IgE mediated, doesn't it?
I agree with you. I don't think it's IgE mediated, but according to that paper, 70% are developing IgG antibodies to the PEG, which is interesting. And that you wonder, and there's no way for us to test it, but maybe it is an IgG type reaction.
Yeah, so I'm thinking that maybe some of these reactions may be also a little bit of complement-mediated reactions, like a serum sickness type reaction that you see in most of these. Yeah, but I think I suppose the take-home message is the same, which means to say that even if you could skin test these individuals, if the skin tests come out negative, it's a question of whether that would change your decision as to whether you would vaccinate them with the second dose or not.
That's a good question. I think it depends on the severity of the delayed reaction. I think like the nurse who had the more local type reaction, I probably would consider again probably a graded dose. I think that's not an unreasonable way to do it. Like give you 0.1 and then maybe the 0.4, the rest of it.
Yeah, in fact, the graded dose challenge was something we were thinking of initially, but looking at how you have to even just draw 0.3 mils of the Pfizer vaccine, I think graded challenges do seem to be rather challenging, given the very, very small volumes that you have to challenge with. So I'm not sure how accurate that would be, honestly.
We used to do it for the flu vaccines, and so we felt it reasonable. Yeah.
Yeah, I think flu vaccines and the other vaccines are a little bit simpler because at least the volumes are a little bit larger. It's more easy to handle. Yeah, we've had quite a bit of problems and challenges with the Pfizer with the 0.3 mils, and I think there's always been this interest trying to get the 6 dose out of every Pfizer vial, which people have been quite successful with the new syringes that are now available, which removes the dead space. So instead of using the insulin syringes, I think we managed to get the special syringes, which is able to draw up the last dose. But our recommendation for our vaccinators have always been not to try to be too enthusiastic trying to syringe that last dose out, because we do have this theory that perhaps if you syringe it too hard, you might disrupt the lipid nanoparticle. Now, whether that's fact or fiction, we don't know. We haven't been able to see any particular pattern between people getting the first 1 or 2 doses from the vial versus the people getting the last couple of doses where it's forcibly syringed out. We don't know. Have you seen any of these patterns?
No, I'm not aware of anything like that.
Yeah. So I think it's pretty interesting.
I would be a little surprised, quite frankly, if it was different for the first or the last, because it's in the manufacturing process. You would think it would take care of that.
Yeah, so we've told the vaccinators in particular, when they reconstitute, not to agitate the vial too much in order to ensure at least some homogeneity. And we've been very careful about the storage, the expiration, the using it up within the first 6 hours. Those very strict rules about it. Have you seen a lot of delayed reactions more in terms of exanthematous rashes, like a viral exanthem type of eruption?
I haven't seen that many, not just rash reactions. I mean, obviously you see people, getting flu-like symptoms, aching, even some low-grade fevers and some GI upset and things like that. But I think that's pretty much a normal reaction. I mean, not unusual.
Yeah. So we've seen quite a number of these, in particular after we started giving the second doses. So I'm not sure whether it's a healthcare worker phenomenon, but somehow the healthcare workers seem to have got a pretty significant reactions following the second dose, even though the first dose was pretty asymptomatic. So in fact, as a practical point, we've asked individuals, in particular before the dose, after the dose, to try and optimize the situation, be in as ideal a situation as possible when they come for the vaccination. Make sure they've got a meal, they haven't been too dehydrated, they haven't been too stressed. In particular, sometimes we've scheduled the nurses after their night shifts. So when they come down for their vaccinations, not exactly the best times, I think, after a night shift and after all the busy work. So we've been trying to schedule things, and it's been very challenging because you need to group 5 people together for the Pfizer vaccine. So if you have one person who drops out, it's a bit of a logistic nightmare on our end.
I think your suggestion for hydration and have them eating well is a very good one. In fact, in one of the patients, the male in our survey, he had not eaten beforehand, and he didn't really want to drink anything. And he said it was kind of in a warm room, a hot room, and you wonder if that was a factor as well. So I always encourage people to drink and eat something before they get it.
Yeah. In particular, when they start getting syncopal episodes and other very non-specific symptoms in adults, I think that's very tricky during the 30 minutes of monitoring.
Right. Yeah.
So just maybe a slightly different slant. I'm not sure whether you've seen a lot of vaccine stimulated autoimmunity in the patients who have been vaccinated in the US, or maybe they end up with the rheumatologist. I'm not too sure. We've been seeing a couple of cases of what appears to be post-vaccine hyperthyroidism, patients who are symptomatic. But it's again a little bit difficult to say whether it was just perhaps an underlying autoimmune condition in evolution, or whether the vaccination had absolutely anything or nothing to do with it. What's been the experience in the US? I know there's a lot of interest in this from the regulators.
Well, I quite frankly, I don't know the answer to that. I'm sure somebody's looking at that, but it'd probably be a bigger academic center. So I don't want to say that it, pro or con.
Yeah. Okay. Okay, Ruby, you wanna carry
Thank
on?
you for that. That was lovely. And before I go on to some of the questions that I had decided to ask Stan, I would like to just pick up from where this discussion was with Bernard. And I think that one of the things that he raised about this delayed reaction, I've come across this through friends of mine who've had this kind of discoid lupus, in an elderly woman about 70 years old. And it flared up post the first vaccination. And it didn't happen on the day of the vaccination, but say about 5 days later, and there was a flare of the discoid lupus. Of course, the patient was taken off steroids for about 5 days prior to the vaccination. But we don't know if this was a reaction to the vaccine or whether this was just a flare up of the discoid. And one of the things, she didn't have any systemic lupus, of course. And one of the things that was suggested was also to look at the C3, C4 complement, as Bernard also was just talking about. So do you have such kind of cases, or if so, would you also do the complement testing for immune complexes?
So that's a good question. I haven't seen that, but in that particular patient, you do wonder about the prednisone and what kind of factor that's going to be. But I mean, we do check C3, C4 specifically, in patients who have those rashes and that are unexplained, just to make sure we're not missing some kind of a immune problem like that.
So in such a patient, you would not advise a second injection, especially she's elderly, and one would refrain from a second.
That's a tough one. That's an interesting question. I'm not sure I would know what to recommend. I don't know, Bernard, what would you do in that situation? You've got some experience with that.
It's kind of tough for the elderly, because now in Singapore we have started rolling out the vaccinations for the elderly population. They started it about 2 weeks ago for the 70-year-olds and above, and so they're going to start it a little bit more widespread in the community this week. So I think if you talk to the geriatricians, there are differing points of view if you talk to the geriatricians versus like the ID physicians. So of course, the ID physicians will tell you that, yes, you should try and vaccinate, in particular the elderly people, because they have cardiovascular comorbidities. If they were to catch an infection, they would be at higher risk. But if you talk to some of the geriatricians feel that, in particular in the frail elderly, for example, some of the frail elderly in the nursing homes, for example, long-term care settings, who have already multiple medical problems, the last thing that you want would be for them to end up with a vaccine-induced, say, reaction, not just anaphylaxis, but maybe even a febrile episode, increase their risk of aspirating. So then how do you think the benefits of the vaccinations outweigh the risks? So a lot of questions.
Yeah,
so that's an interesting point, and I think you're right. In those types of patients, I can understand why the geriatricians are saying that, especially because you do get a fair amount of immunity even after the first dose.
Yes, exactly. That's the point I was saying. I mean, in a case like this, an elderly woman who has this, and we don't know whether this was just a flare-up of the discoid or it is basically a result of the polyethylene glycol, and she's actually has had Tegretol before. Tegretol also contains PEG, if I'm not mistaken. But again, we cannot really say that because she had Tegretol, it's okay for her to have the Pfizer vaccine or not. So, I mean, the general opinion was to actually hold on to the second because she already would have some antibodies from the first vaccine, right?
Yes. I would say that's probably true.
The other thing I also, before asking the questions that I had set up, was also catching on to the questions that Bernard had raised, is of this gradial or gradation of the vaccine, And yes, we do that for influenza, we do that for other vaccines. The biggest challenge with the Pfizer vaccine is because of its storage and the duration in which you can keep it at 2 to 8 degrees. So if you're going to give it in gradation, then will you be giving it from the same lot, or will you have to give it from different lots? How would you do that? Because it would have to be done over a period of time.
What they did at Emory was they did them from the same lot for those patients in that one day, but it was the one day, and they just gave the small, and then they gave the second dose right away. It probably was not the same lot that they had from the first dose, but
so it was not split over a number of days, right?
No, yeah, it was that same day.
Yeah, that was my key question, because if you have to split over the number of days with this, the second point again in relation to this is, supposing a person has this severe reaction to the PEG, would you advise, or what's the recommendation in the US? Would you wait for another vaccine like the AstraZeneca or some other vaccine to be made available to do that? Is that a recommendation that one would do? Is it okay to switch over to another vaccine?
Well, the problem, my understanding is that the other vaccine has a polysorbate in it. So it may not be completely safe for that patient to receive that either. I don't know. That's a big quandary.
Mm. And also there are others coming up, which may not have either. So the big question is that can we use the second dose from another vaccine as compared to using both the doses, or giving the second dose?
Wow, I'm not sure. I don't have that expertise. I'm not sure I could say
No, no.
that. I don't know.
What I meant is
Anand, what do
there a
you?
consensus on that
Yeah,
in the
I
US?
would say, if you're trying to induce antibodies for spiked proteins, and each of the vaccine does, and I know the WAO paper lists a variety of international type vaccines that are available. I'm not that familiar with them, but it's probably not unreasonable.
I see. Yeah,
I
because
think
even the World
Here,
Health
Bernard, what were you
Organization.
going to say? Let Bernard answer. What were you going to say, Bernard?
I think in Singapore, we are quite strict about it, about keeping to the same formulation for the second dose. I think partly because of the way in which the vaccine has been approved, because it's through a emergency access program, so there are regulatory restrictions with it. I think the problem if you have two different formulations of dose 1 and dose 2 is that if you get an adverse reaction, then you're a little bit stuck. You may not be very clear which one caused what. So that's why we're very cautious about it. And we're trying in Singapore, we're trying not to mix the Pfizer and the Moderna vaccine, making it available at the same vaccination sites. Also to make sure that to try and reduce and mitigate the risk of errors in the event, because the draw volume for each are totally different. So we're trying to reduce medication errors. So we are trying our best not to have two vaccines of two different types in the same center, or at least in the same site.
Gotcha. Good.
Yeah, actually, this is exactly what I was just about to say, because the World Health Organization had a press briefing on this, and they said exactly the same, because they were asked the same question, that would you recommend giving another vaccine from? So my friend and classmate, who is the chief scientific officer there, was interviewed, and that's their recommendation also, because currently all the vaccines are just for emergency use, and they're all still being studied for long-term effects. So at this moment, that they wouldn't advise, because there's no evidence to show that it could be safe, so they wouldn't advise giving two different vaccines as the first and the second shot. So yeah, that's the recommendation from the World Health Organization. So yeah. Then the other thing that I was going to ask is, now many allergy organizations, the American Academy of Allergy, the American College, the World Allergy Organization, YACI, our organization, Apache, many of these organizations are especially coming up with guidelines for the severe adverse reactions against the COVID vaccine, especially because of the initial report of anaphylaxis, and then, of course, with multiple other reports, though it's not so frequent. So what I'd like to really ask is this, as we're providing, for us, it's very important at this stage, because the countries is just rolling out the vaccines in the Asia Pacific region. So when we look at these, our recommendations are based on CDC or World Health Organization or FDA or EMA. And would you like to comment on the recommendations that we have put forward from Apache?
The sheet that you sent me, I think it's excellent. I think that the recommendations you have are very good. You're talking about this paper here, and it's very well referenced, and it's got good background in it. And again, I did look at cite several of them that I think are very very poignant, and I think it's a very good service for the members.
Thank you very much. The other thing that I was interested in knowing is, like, monitoring is very, very important. And one of the things that, in your presentation, you talked about 30 minutes monitoring, but I remember the initial UK guidelines, and I think even from FDA, if I'm not mistaken, the initial monitoring time was set to be 15 minutes, more than 30 minutes.
Correct.
If I'm correct.
15 minutes. 15 minutes is the typical normal react. Yeah.
For us, we have always thought that 30 minutes is important. So that's what the guidance that we have put in these guidelines. But as Bernard has also already said, that there are cases where they develop symptoms even 2 hours after the injection, like rash. So my question is, like, when people have allergies, like food allergies or prior history of anaphylaxis, this is really in a well-developed country like Singapore or Japan or Korea or United States or UK. This is well established. We're looking at a region where EpiPen is not even available in many countries. People are not really aware of what is anaphylaxis. Not all people know they're allergic to certain kinds of foods. So we're really faced with a challenge that how do we recognize this, because we can't go on testing PEG in every individual before actually administering this. So is there something that you would like to recommend that we could suggest to our community?
Wow. Bernard, maybe you could answer, because you're closer to the countries that are in that situation than I am.
I'm asking from the US perspective.
Oh, from the U.S. perspective, I don't think I would test everybody for sure. I mean, I think that you have to have a history. You have to be concerned about it. But I think it's probably reasonable, as has been recommended, is to be able to identify and treat anaphylaxis, when you give the vaccine. So make sure that you have those facilities available, just like we do with any kind of injectable. So I think that's probably a wise choice. I think the choice between a 15-minute wait and a 30-minute wait, it doesn't sound like a lot, but logistically, if you're giving a lot of vaccines, like when I went to the hospital to get mine, and we had people waiting all over the all over the waiting room just the 15 minutes. So you got to be careful about your recommendation, and I think that for the patients who are at risk, the 30-minute wait is very appropriate, but it may not be necessary for most people.
The other thing is about allergy testing. Are there any lab-based commercial, maybe non-FDA approved anti-PEG, IgG, IgM assays that are available in the US?
Not that I know of.
Okay. And for the skin testing, like we have some of the drugs, of course, like as you said, Miralax. So like there might be other drugs which also contain PEG. Could they be used as alternatives to?
Oh yeah, I would think so. Sure.
Okay. And then the other question is like the interval between the two vaccinations. This again is a big issue, because in the initial phases, it's easier to keep that 3-week interval for Pfizer. But as time goes on and people don't have enough vaccines left, they start spacing out, like what they're doing now in the UK. Is that justified? Does that make sense? And do you have any recommendations personally on that?
That's not one of my areas of expertise, so I can't really say. The studies, as you know, are basically based on those intervals, so we really don't know. I think that in general, if you wait a few weeks, it's probably not going to make that much of a difference. Like we do for the pneumavax. When we see a pneumavax response, we're looking for an immune, a hypogammaglobulinemia type patient. If they miss a week or two, it's not really going to make that much difference. But I really don't know the answer. I don't know, Bernard. Do you know? You want to say? Speak to that.
In fact, I was just going to ask, in the US, right, when you do the skin test, what's the time interval between the first dose and the skin test that you allow? Up to about 4 weeks? Because that's what we kind of felt would be a safe enough period. We thought that doing it 2 weeks, 3 weeks might be a little bit too early. So we felt in Singapore that perhaps 4 weeks would be okay. If your skin tests are negative, then you can proceed with the second dose within the next 7 days or so. So about 4 to 5 weeks between the 2 doses of Pfizer we felt was probably still appropriate. What are your thoughts on that?
I think that's a very good way to do it. Although I'm not sure you really need to wait more than a couple of weeks after the reaction. I'm not sure it's that necessary, but.
We just wanted to err on the side of the caution to ensure we don't get a false negative skin test. And then if you get a false negative skin test, then you challenge, you might get a reaction. I mean, that was
Well,
the
that's a good point, and that's certainly, why I think it's a good way to do it. It makes a lot of sense.
Yeah.
The reason I asked about spacing of the vaccine was for dual reason. One is from a public health point of view in this pandemic, and one is for the protection of the individual. So when you think of the protection of the individual, you would go according to what science says, and according to the science is like on Pfizer, you give 3 weeks after, But what they follow in UK, they're trying to create something like giving larger number of people, protecting larger number of people, and thereby probably trying to create something like a herd immunity that could, dampen the, future increase of infective cases. So I think it's a clash between public policy for trying to get herd immunity and what science is saying.
Yeah.
Yeah. So yes, Bernard, any questions from your side?
So I had two very US based questions, which I wanted to find out what the situation was in the US. So I am aware that there is this app called the VSafe program, which is set up by the CDC, where patients who have had vaccinations are supposed to be encouraged to self-report their adverse reactions. Is it something which is very, very widely used by the public there after the vaccination?
I'm not sure that is as widely used as it probably should be. It'd probably be a good idea, but because they are trying to collect, as that JAMA report was, from the VAERS, the vaccine, reporting system. But I don't think that it's being reported is the way it should be.
Yeah, I think it's the same problem like our staff vaccinations. The motivated people would report all their reactions, and the people who you would want to report do not report their reactions. So we've even had staff who only tell us like the day before their second dose that, by the way, something happened after the first dose. Then we go like, yeah, right. This is a little bit late. Now we have to reschedule you, that sort of thing. So that's been the experience in Singapore. In Singapore, we don't have this system yet. So we saw the one on the CDC website. We were quite excited about it. So we thought, yeah, it would be good if everyone had an app.
Yeah, in fact, in India, they have an app now. They have an app that they use for reporting any reactions, and they collecting that data in the ministry. So they have an app that's doing that. In Japan, also, there is a kind of system of collecting the data, but we've just started rolling it out to the health care workers last week. So we are also just about to get our vaccinations maybe in a couple of weeks' time.
Yeah.
So
But
it's going to be a while before we can get some data here.
Okay.
But I found that the photographs of the rashes that the individuals develop have been very useful, because we use that as one of the triage decision trees to decide whether the patients should just avoid the second dose, or whether in the doubtful cases, whether they should be seen by an allergist, skin tested, because otherwise we anticipate that there will be a lot of individuals who will need to see an allergist. So we just needed some more rational way to triage so that not everybody ends up with us.
No, I think that's, yeah. Go ahead.
Yeah, the other thing I was quite interested in is this National Vaccine Injury Compensation Program that they have in the US. I wasn't aware that it's been in existence for so long already. And I think the reason we've been a bit interested in it is because in Singapore, we've tried to set up something equivalent. What's the experience in the US been like for these vaccine, injury compensation programs?
I don't know. I can't speak to it because that's not really one of my areas of expertise. I do remember that it was set up. I think it was set up when we had, I guess it was in the 80s, a lot of Guillain-Barré for the flu vaccines and all. So I think they started to set it up then, but I really don't, I'm not familiar with it. I mean, I can't speak to it. Sorry.
Yeah, it's okay. In Singapore, we've never really had such a program. So specifically for the COVID-19 vaccination, it's been established by the Ministry of Health. It's tricky because I think it's a question of how you attribute causation to the vaccine. That's one problem. And the second problem is that because it's a voluntary vaccination program, at least in Singapore, I suppose it's a little bit hard when it comes to adjudicating whether someone qualifies for the to claim from the vaccine injury program or not. So a lot of uncharted waters here, which we're not very familiar with ourselves. Yeah.
Good.
Okay.
Anyway, no, I think it sounds like you guys are approaching it from a very very scientific and logical and practical way. So I think that's to your credit.
Yes, I think the countries here are really looking at good ways of doing the AEF eyes and making good protocols to actually stratify the groups of people that they are vaccinating. And yes, I think this is something Bernard and I had also discussed, and probably I thought he would raise it up. We do our vaccinations usually in the hospitals and in polyclinics, or are you doing that, or in like public places where
No.
Okay, it's always in the hospitals.
Yeah, no, I got mine in the hospital, but that's, because I'm, a health worker. But now they're setting them up in major, in sports arenas. They have vaccination centers in our local, sports, our football stadium. And you're going to see that around the country where they set up these mass vaccination centers. And they're trying to get it rolled out to more people.
Yeah, but while in doing so, are the vaccinations being given by medical doctors only, or by doctors and nurses and physician assistants or pharmacists? How do they do it?
I think they're trained. They're usually not physicians. They're usually healthcare workers, but I don't think that they have any particular degree necessarily. I would hope that somebody there can identify anaphylaxis and have something, some epinephrine there to treat it. And I would imagine when they set up their center that they have that. But I haven't been involved in setting those facilities up.
So in Singapore, the way we've set it up is that at these community vaccination centers, in a way, it's outsourced to the private family physician groups to run. So for every center, there will be nurses who will be deployed there to carry out the vaccinations. But in addition, there are also medical staff there, doctors there who will attend to any anaphylaxis situations. And they've also worked out the evacuation route should there be an anaphylaxis episode to go to the nearest public hospital. But I think Singapore is a bit easier to do this because it's a bit small. Things are a bit self-contained. I think in large countries, in particular rural areas, suburban areas, it might be a little bit challenging, the logistics of organizing these community vaccination centers.
Yep.
And one other question I was keen on knowing is, in those who have food allergies, and it's not contraindicated, but would you pre-medicate them with like an H1, H2 receptor and Montelukast prior to the vaccination? Is that something we are also doing here?
That's an interesting question. I haven't really done it routinely. I don't think it's going to hurt if they take an H1 or an H2 beforehand. But I'm not sure it's going to stop an anaphylactic reaction either. So I don't know, Bernard. What are you recommending, Bernard? Sounds like you guys are pretty well set up for this.
So we've had we've had healthcare workers who have pre-medicated themselves. For some it worked, for some it didn't work. They still broke through. Some of those who had the exanthems, urticaria, still broke through. So in Singapore, our recommendation in particular would be for the patients with chronic urticaria, eczema. If they have been on a stable dose of antihistamines, we encourage them to just keep that stable once a day, twice a day dose through. In order for them to not have breakthrough urticaria, breakthrough eczema after the vaccination, which then makes it a little bit hard to decide whether the vaccine had anything to do with it or not. I think recently we were also asked about patients who are on biologics. So for example, the atopic dermatitis individuals on dupilumab, the chronic urticaria ones on omalizumab. whether they should continue to be on the biologic while they go for the vaccine. So our recommendation has been that if they are very stable, keep them on the treatment and don't try to taper or do anything that you usually would not do around a new episode. And once they've finished their 2 doses, then you can do whatever you want. You can taper or do whatever. That's been our recommendation.
Yeah, we've usually been recommending that they receive their biologic, like their dupilumab, like a week before they get the vaccine. Make sure there's a week interval. And the same thing, like don't get your dupilumab until you've been a week after the COVID vaccine.
Yeah. It just requires some logistics, I think, but it can be done.
Yeah, that's right.
Yeah, but generally they say not to give steroids along with the H1H2 prior, because it could dampen the effect of the vaccine.
Well, I suppose it depends on what dose of steroid and how long it goes on for.
I mean, oral steroids is one of the things that came in as a recommendation in one of the papers.
Right.
Yeah, that we should avoid because it dampens the viral, the vaccine effect.
Yeah, the antibody response. But I mean, again, as like Bernard said, if it's not a big dose, it's probably not, going to really impede your immune response.
Yeah.
Okay. No, the reason I asked is because when we want to pre-medicate them, I think we just want to give them the minimal medication that we think might help them. At least, of course, it's not for someone who has anaphylaxis will come with it. I mean, such a patient, at least in countries like Japan or Singapore, Korea or Australia, would have an EpiPen in hand, or Hong Kong. But again, like in many other countries, they don't have EpiPen even available there. So it's a risk. But I don't know. I mean, again, we have to see what's the data coming in from India, because they haven't yet published anything. We have in our task force actually one of the national task force professors, Dr. Guleria, who's actually in charge of these AEFIs. So we hope we can get some data from India too.
Good.
So in Singapore, we are so cautious that currently any individual who has had any anaphylactic episode from any etiology, including food, insect venom, stings, have not been allowed to be vaccinated as yet. Until we gain more experience, then we'll let them through. Yeah, so when they compare with the US and the UK guidelines, people are a little bit upset that they can't be vaccinated.
Well, I think we're going to be much better. We are going to be more relaxed here, because I'm going to get my vaccine, even though I'm anaphylactic to crustaceans. Anyway, that was really wonderful, Stan. I deeply appreciate the excellent talk and the question answers, and thank you, Bernard, too. And I think this was a very, very useful information and discussion that I think many people will benefit from it in our region.